this is a public meeting, hence the record, and we will publish the recording. So yeah, treat this as if you're speaking in public.
Thank you for that, David. That's fine. And just before we get into the meat of the meeting, as it were, a couple of procedural issues. Remember to mute your microphone when you're not speaking. If you want to ask something, use the hand signal, put up your hand and I'll come to you. And I'll make a note of the order in which the hands go up so that I'll come to you in turn. It's lovely to see you all, but don't feel you have to keep your cameras on the whole time if you don't want to. That's entirely optional, but it is very nice to see everybody. I have to say I miss you all.
Nuala, could I just say one thing, Peter Phillips?
Hello, Peter.
Last meeting when you couldn't see me, in fact, I did try the hand up thing and it didn't work. And Claire said that sometimes when you're working on a home computer, it doesn't work. So in those circumstances, do you still want us to use the list on the right?
You can do, but also if you, I mean, if you're keeping your camera on, you can physically put your hand up as well. That might help. But by all means, use the meeting chat on the right,
okay.
And that would be, you know, I'll make sure I keep an eye on that as well.
It may work today, but we'll see anyway.
See how it goes. See how it goes. Okay, right. Well, welcome all. A particular welcome to Louise, who officially joins us next week, but it's lovely to have you here with us today and for you to virtually meet the rest of the board. We're delighted that you're going to be joining us. It's strange circumstances, but we're very, very happy to have you on board. So welcome. Also, welcome to Joe Bettison, who is here to share a staff story with us this morning. Lovely to see you, Joe, and we look forward to hearing your testimony. And Becky Meacham, who is our CQC relationship, is it manager? Is that the term?
Relationship owner, but same.
Yes, I saw that Steve called you the relationship owner, which I thought was rather strange. But
yeah, it is a strange phrase.
But anyway, you're most welcome, and you're here as an observer for this meeting. I don't know if there's anything in particular you're looking for, anything we can help you with, Becky, but you're most welcome anyway.
Thank you very much. Thanks.
Right. So that's the welcomes. We have no apologies. So can we go to the minutes of the meeting held on 26th of March? And if you could, excuse me, check those for accuracy first. If there's anything that you need to change, let me know. If not, we'll go straight to the action log. And on the action log, the learning from deaths is on this agenda, Jane, so we don't need to hear anything about it now. And Robert was going to follow up on the visits to the architects to Whitchurch, but I'm guessing that that's also on hold at the moment. So we will be updated on that later.
Nuala, that relates to a particular couple of rooms, and we're starting to work those up separately, but that's running forward anyway. So that is being actioned.
Okay, that's great. Okay, thank you for that.
Just to interrupt, what we got on share screen here is the Resource and Performance Committee meeting.
Thank you. I was going to say I didn't recognise that as what's on mine. My action log has only got those 2 items on.
Same for me.
My fault. I hadn't shifted back to the board papers. My apologies. I'll do it now.
Right, that's all I have. Those are both now dealt with. Thank you. Any new declarations of interest that not previously informed about? If not, okay, we're on to my report, which is there just to give a summary of the matters that we discussed during the confidential part of the board, and also the activities that have been conducted over the past couple of months, just there for information. Happy to take any comments or questions if there are any. That's fine. Thank you. It looks as though nobody's indicating. Thank you.
Chair, Chair, can I just come in? It's Harmesh here.
Harmesh, hi.
Hi. Just on the meetings and business, I know, Chair, we haven't had the opportunity to visit our sites. I was just wondering, to give sort of moral support to our staff and to be seen within the community and within our hospital, would it be possible to arrange some meetings as long as we can abide by social distancing rules?
Well, others can answer that, but I actually have a view, Harmesh, that at the moment I personally don't think it's wise at a time when, you know, even visitors, family members are not being allowed into hospitals.
Okay.
I'm not sure that it would be helpful to have us there. What I am intending to do later today, you're aware that we do all staff briefings, and I'm going to join in on this afternoon's briefing on behalf of all the board, really, I'll give a brief report back on what we discussed today, and also do exactly what you've just mentioned, Harmesh. I mean, that was my main objective, just to show a bit of visibility, support for our staff, say that we're thinking about them, you know, all of those things. I do understand where you're coming from, but and others may want to contradict me, but I think we set a good example by not undertaking unnecessary visits. I think that's our role at the moment. That's my strong personal view. I don't know if anybody else wants to comment. I can see a hand up, but I can't see whose hand it is.
Me, Steve Wheeler and Jackie as well. But so I would just concur really with your points, Nuala. But Harmesh, you can probably imagine we're all quite frustrated with the fact that we like being visible and we like being there to be able to see what people are doing. So it's incredibly frustrating for us all. But our staff, I can tell you, do fully understand that. And actually, if you go back to Nuala's point, I think it's really important that we also do completely abide by all the guidance that is out there, including the social but clinical distancing. So I think people are understanding of that. But we do have visibility through other means. It's just not the physical presence that we're used to.
Okay, thank you for that. I mean, I support that and understand that, Chair. I was just conscious that we haven't been out, and it was just to provide that level of support and to be visible. But if you're doing that, I'm happy to accept that. Thank you.
But thank you, Harmesh, and I understand where your comments are coming from, and I will make sure that I express some of that when I speak to staff this afternoon. I can see another hand up. For some reason, I can't see who it is.
Nuala, it's myself. I mean, similar comments to Steve, and I think.
Hello.
Hi. Similar comments to Steve, really, and to say we are going to do a piece of work around how we work in this next phase and how we work in the longer term, and we'll include you discussions with you around that. So I think the assumption is that we wouldn't necessarily go back to exactly as we were before. So there's a new normal, and we need to define strategically what visibility means. I think the board could be assured that actually, I think that there's certainly some views that it's enabled us to be more visible from in some ways, and there's more engagement using some of the technology. But there is a role in the longer term, no doubt, for face-to-face. But we'll plan that and work that through with your involvement.
Thank you, Jackie. Thanks for that. And again, I see another hand, although it's not showing me whose it is.
It's me, it's David. No, just on nothing to add to what Steve and Jackie have said, but just on the technical point of seeing who's waving, so to speak. Are you on the people? If you press the people button, you should see a list of everyone on the call and who's got their hand up.
Right, it's just saying plus 16 at the moment, but I'll have a look. I'll have a look for that.
In which case, if it isn't working, maybe Claire, you could help Nuala navigate as people raise questions.
Yeah, will do.
Okay, thanks.
Yeah, it's just showing that there is a hand, but it doesn't show me who it is at the. Oh, let me see if show participants. Right. Okay. Let me see how I get on. I'll do my best for you. Right. Was there another point, David? Or was that it?
I just nothing to add to Steve and Claire. I think that's the right approach.
Right, well, stay where you are, David, because if there's no more comments or questions on my report, then you're on next for the Chief Executive's report.
Okie dokie, thank you. So this report is the normal Chief Exec report setting out national and local issues which might be relevant to the board, not covered elsewhere on the agenda. It does feel like quite a long time since we had our last board meeting, because you will recall we've changed the pattern of board meetings. So this is a slightly longer gap between meetings than we would normally have. So it's a little bit of catch up to do. I will assume, as is normal, that you've read the report just to highlight the main issues it's covering, and then very happy to take questions. Clearly, most of the work we've been doing over the last couple of months has been focusing on management of COVID. That's not surprising given the pandemic and the national direction that we've had. So almost all of this report relates to that. So what it's setting out is where we've got to in terms of governance and our place within the system and regional processes and national processes that are in place. A little bit of an update about restoration and recovery. So the board will be aware we've moved from the initial phase of managing the initial crisis to a restoration phase, and then the next phase will be recovery. And what I've included in the paper is a communication that has come out from David Evans, the Chief Exec Accountable Officer of the CCG, setting out the system approach to restoration and recovery. I've also highlighted our role within Shopcom within testing, and in the report refer to the likelihood that antibody testing is going to be made available. So I can do a quick update for you on that, because as with much in the COVID world, it's a fairly fast moving position. So on antibody testing, as the board will probably be aware, an agreed antibody test that is validated has now been signed off by Public Health England, and it is now being made available to the NHS. It has started to be made available elsewhere in the region. We are looking to roll out an initial phase of staff testing within Shopcom and other NHS organisations in the patch from next week onwards. The delay has been to do with testing kit availability and laboratory capacity locally. So we are slightly behind the curve in the sense of pace of implementation. But the intention is to start that from next week, as I say, and then ramp up the numbers over the coming weeks. Just to reiterate, which I'm sure you have picked up, the antibody testing does not give you any sign or information about immunity to COVID. It simply tells us whether someone has had COVID and whether they have present antibodies. So it has no practical sense of, if you have a positive result, you can do X, Y, or Z. You can't interpret it that way. So it simply gives us, at the moment anyway, a idea about the prevalence or the level of incidence of COVID within our staff population. So just out of interest, I've seen the first cut of regional figures on that, and 16% of staff are testing positive who've been tested so far. So it's fairly a small numbers, but in terms of numbers of people tested, but 16% of NHS staff in the Midlands have tested positive. So that gives us some sense of how far the pandemic has spread within our staff groups. So we will be communicating. I mean, we don't have firm numbers yet or detail on exactly how many tests we'll be able to do, antibody tests we'll be able to do from next week onwards. But as soon as we do, we will obviously share that with staff and make sure they know how they can access it. It is optional. You have to have consent from staff to have the test. So it's not mandatory. It's optional, and we will make.
Oh, so sorry.
Sorry, I just finished the sentence. We will make our occupational health team available to provide support for people getting test results, because whatever, no matter how little you can interpret the results, undoubtedly there'll be questions and potentially anxieties related to it. And the final thing I just put in the report.
Hand up. I don't know if she has a question on the specifically on the testing. Is it
okay?
Yes, it is. Thanks, Chair. It was just, I recognise there's been hiccups with staff testing, but have we been able to test those staff that we've needed to test?
So are you talking about the antigen testing rather than the antibody testing? Remember the two types of tests?
Yeah, no,
yes, in terms of yes, the antigen test. So that's testing staff who are symptomatic, basically. So if you're symptomatic,
that's what I'm talking about.
Yeah, no, we've been pretty good at that. So our local testing system has gone very well. There are national testing and regional testing routes as well, but our local team, which we've led on within Shropcom, serving not just our staff but other NHS staff and other key worker staff, has been very, very, very well received. It's been very flexible. It's been very effective. So yeah, we've been able to test anyone who has requested a test who's symptomatic.
Right, thank you. That's great.
The last thing in the report, and I'll open up to any other questions, is just to reflect on, not everything we do is about COVID. So I just related in the report, we are now planning for flu vaccination. That is important in the COVID context, in that coming into winter, obviously, if there's a combination of flu and COVID, that wouldn't be that's kind of not a great scenario. So I think the normal desire to make sure as many of our frontline staff, or all of our staff, have flu vaccinations as possible will remain a high priority, and Jackie and team are on with the planning for that. So I'll stop there, Nuala.
Thank you, David. Any questions? I don't see any hands at the moment. Does anybody want to ask David any questions? A good full report. I note on the, I think it's the final page of, of the written report, you mentioned the shadow ICS board, and I think I'm obviously also attending those meetings, those virtual meetings, and we really have seen the benefit of system working throughout this pandemic, and it's definitely made people work together in ways that, it's accelerated the partnership working by a couple of years, I reckon, and through it, there's a lot of cooperation and building of relationships. So it has been a very positive experience. Claire, yeah. I see you're indicating.
Completely endorse that, Nuala. Yeah, no, the system working and the collaboration between partners has been exemplary, not just health, but with local government and indeed into the wider community.
No, absolutely. Okay, Claire.
It was just really to ask David whether he thought there was anything particular in the COVID-19 dashboard that we have formulated over the last couple of months, because this is the first time we've aired it at a board meeting in public. And if people are listening into the recording, I think it might be helpful if we just give them a bit of context to that dashboard alongside our normal one.
Okay, thanks, Claire. So the dashboard's been developed as a live means for us to keep track of some key indicators we think are important in terms of managing COVID. So the primary purpose for it is to ensure that our local teams are and our management systems are aware of where we are on any of the key indicators. So the dashboard feeds both the Quality and Safety Committee, the Finance and Performance Committee, and probably as importantly, it feeds the incident management team that Steve chairs. So it enables us operationally to ensure we are aware of any our performance, whether there are any issues of concern, and promotes kind of mitigation and action if there are. So that's its purpose. So the version we have it is a live document. So the one we have in the papers is obviously out of date now. So that happens to be the report we have for the 29th of May, which is when we sent the papers out. So it's a live document. So each day we can dial into it and ensure we're on top of where we are in terms of our current position. So taking a random example really of the sorts of things that are on the dashboard. COVID-related sickness. So you'll see on the version we have in the papers, we had 12 on that day. We had 12 members of staff who were currently off sick with COVID symptoms. Now, what's interesting on that is if you look at the trend, probably doesn't show it all that clearly on this particular chart, but if you go back over the last 2 months, you'll see a significant reduction in the numbers of our staff who are off sick with COVID-related symptoms. So at its peak, it was kind of, I can't remember the exact number now, 60 or 70 staff I think we had at the absolute peak. It's now down to 12 as of last Friday. It's actually slightly lower again now, I think. So yeah, that's how we're using it. So it's not designed specifically to inform the board at this board meeting, but we thought it was important for it to be visible to demonstrate how we're using data to support our management.
Thank you. Thanks for that, David. If there are no further questions, and I can't see anyone indicating, can I ask that we all accept that report and move on? And indeed, the next item on the agenda is the staff story. So at this point, we welcome Joe. Joe, you disappeared off my screen, but I'm sure you're there. Joe, can I again welcome you and invite you to give us your experience of working over these past few weeks?
Hello there, good morning.
Hello, Steve. Should I just introduce Joe?
Can you hear me?
Nuala, you're on mute.
Steve, yeah, I suggest you do.
Steve, are you on?
Thank you. Good morning. Can you hear me all?
Yep.
Yep.
Can you hear me?
I can hear you.
I think Joe's suddenly. I wonder if we turned our.
Yeah, hi, can you hear me?
Yes.
Yeah,
yes.
You're okay.
Can you hear me now?
Yeah, go for it, Joe.
Yeah.
I think maybe Joe can't hear us.
Oh.
Can you see us, Joe?
I can see you all, but can you hear me?
Yes. Yes.
I can see you all. Can you see me?
We can.
Yeah, good. Good morning, and this is good. I'm glad you can hear me. This is a really surreal experience for me to present virtually, but thank you for inviting me here today. Can you hear me?
Joe, we can hear you. I can see nods.
Right,
if you
can you hear me now?
We can hear you. Yeah, loud and clear. Yes. Yep.
I can hear you, but not very many. Can you hear me?
Yes.
Yes.
Good.
Yes.
Yes.
Yes, we can all hear you, Joe. Keep going.
You can. Okay, right. Should I start? Thumbs up, great. Okay, thank you all for inviting me here today. I work as a family nurse with Family Nurse Partnership, which is an intensive home visiting service for teenage mums. And can you hear me all right? And I just wanted to talk to you today about my experience of redeployment over the last 9 weeks. I came back to my base of FMP last Wednesday, having been out since mid-March. I guess my opinion is one that might not be shared with everybody. So this is You can hear me.
You're cutting in and out.
Can you hear what I'm saying?
Yes, but you're cutting in and out.
Can you hear what I'm?
Yeah.
You can.
Yeah.
Okay, so I started. I was told I was being redeployed on in the middle of March, and it was a very, very quick exit from the service, which for me felt really uncomfortable. And although it was a very unprecedented time for all of us, I guess it just felt leaving service that had so many vulnerable clients, over 100 vulnerable clients, all girls under the age of 19 who were pregnant or who had just given birth to their first child. To leave them with no one felt very uncomfortable. Oh. Yeah, it's not very smooth, is it? Can you hear me?
Yeah, we can hear you, Joe. If you just keep going, it's a bit odd because you probably don't get feedback.
Keep talking, keep talking.
Can you hear me at all?
Joe,
I can't hear anybody now.
I think we can all hear you. You do from time to time.
Can you hear me?
But on the whole, we can hear you. So just keep going, keep talking. You're fine. You're doing really well.
Right, should I just keep talking?
Just keep talking. Absolutely,
Yeah.
We're listening to you.
Okay.
We're listening.
Okay. Yeah. Okay. So I left the service very quickly, and we had to attend training the next day, which was annual leave. I was told I've got to come in on my annual leave. It was all very sudden, and I was told I was going to the community children's nursing team within the trust, which for me, I have to say, I was okay with that, because prior to joining Shropshire Community Health and coming to Shropshire in 2009, I was a community nurse leader for 14 years. So I was quite comfortable with where I was going. I think for myself and my colleagues, it was the fact it was done so quickly without what we felt any thought for the services that we were leaving. So we left and we started with our teams. We spoke to our manager, and one of us was able to stay in FMP and firefight basically all the safeguarding concerns. And I very quickly adapted to a new way of working. And I decided that you could either be negative and you could moan, or you could be positive, you could embrace it and support each other, and just know that we were all in the same position, and we all had to just look after these children and families the best we could in a new area. And I was able to, I hope, give quite a lot to the CCN team while I was there. And I was able to give some clinical ideas that they hadn't got, and they embraced them. And I was able to participate in team meetings, and I know that was really appreciated. Certainly, the time while I was there, it was a very different period of time for the CCN team, because a lot of the children were shielding, so we couldn't see as many children as we normally would, and of course we couldn't car share. So the information you would normally get, you couldn't get that, because you were just following people around in the car and having to go on Rio to look at what the children's conditions were before you went. I decided to write an article about my time, and I just did it one Sunday afternoon, And I thought, I'm going to make something positive out of this, because I had really enjoyed it. Although I was really wanting to go back to FMP, I was really looking forward to sort of talking about my time in CCN. So I sent a draft off to various journals, and all of them were really interested. And in fact, the Nursing Times have published my article today. It's gone online today, so I'll put it on Twitter later. And I'm happy to share that with you before I go, or I'm happy to answer any questions that you may have.
Thank you very much for that, Jo. That's really interesting. I'm just going to kick off and say I think we'd love to see a copy of the article. If that, where can we find it? That would be really interesting to see.
It's on the Nursing Times. It's online actually today, and I'm also going to put it on Twitter. So if you follow me on Twitter, Jo Bettison, you'll see it.
Great. Okay.
Nuala,
okay.
Nuala,
Right. Steve, I can see you. Yeah.
I'll share it with the board, Nuala, because I'm
Thank you,
conscious
Steve.
that not everybody may well be on Twitter. So I'll do that. But well done,
good.
Jo.
Yeah, no, well
Thank
done,
you.
and well done for mastering the technology. It's not easy, and it's
it's
taken us a
not.
while to get used. And we share your pain in the sense of having to get used to working differently. And I liked very much your attitude that you could either be negative and moan about it all, or you could be positive, and the fact that you found the positives in the new way of working. You know, was really, really good to hear. So thanks for sharing that. Right, colleagues, I can see some questions coming up now. Tina?
Thanks, Chair, and thanks, Jo. I'm Tina. I'm one of the non-executive directors. Thanks for
Hi, Tina.
That story. You said early on that one of the key pieces of learning was that the service closed for one member of staff fairly relatively quickly, and I just wonder, with hindsight, and if we were going through the same process again, how do you think that could have been done differently?
I guess what I think we should have done was perhaps stagger the redeployment of very vulnerable services like FMP, where the clients are incredibly fragile. So I think to have taken us all out in one go was a lot for them. I think it would have been better to have taken us out one by one over a period of time and just seen what the demand was like in the areas we went to. Because what we found was that certain areas like adult district nursing, they didn't actually need us. So we came back from there. CCN, they only kept so many of us, and the others came back. So I think FMP, particularly FMP, because of how specialist it is, could have been left with more members of staff and seen how it went.
It's really powerful learning. Thanks.
Thank you. Thanks for that. I think, Sarah, you were indicating first and then Steve.
Thank you. Hi, Jo. Yes, I'm Sarah, and thank you for sharing.
Hi there.
Hello. Hi. Jo, I'm just wondering about how things are now. So obviously you're away from your existing role, your permanent role for a while. You've now returned to that. How are you managing now you've got back? Are you finding that you've got a backlog of work, or are things pretty stable? I'm just wondering how the team have settled back in.
It's been quite difficult because while we're away, there were a lot of serious safeguarding concerns that were raised amongst our clients, and obviously a lot of them don't have anywhere else to go but to us. So social workers have been holding a lot of stuff that perhaps we could have managed better to prevent it escalating had we been there. And of course, because of lockdown, domestic abuse we found has certainly increased, and just neglect and depression has spiraled as well. We're obviously working virtually now, except for essential visits when we wear our PPE and we go out. But we're using a lot of innovative ways. We're using a lot of FaceTime. We're doing a lot of role play via FaceTime. But it's not very easy to assess risk via FaceTime, you know, and we use a lot of intuition and gut about what is going on within a home and what we can see. So we're having to use remote working a lot, but it's going okay. Some of the girls like it, some of them don't as much, but they're all realising that that's the only way we can work at the moment. But we are arranging more and more now, sort of walks in the fresh air, social distancing. We're not seeing any ladies, obviously, over 28 weeks. And we're doing just virtual working with them. But we're trying our best, and we're hopefully getting on top of things.
That's good. And you've got the support you need, Jo, have you?
Yeah, we're a really, really cohesive team. You know, we work really, really well together, and we all support each other massively. And we just all pull together. We have supervision, and you know, we have safeguarding supervision as well. So that just carries on virtually at the moment too.
Thanks.
Thank you. So Steve, and then I'll come to you, Harmesh.
Yeah, probably just two things really to respond to, which is I think the point about the safeguarding, that's probably quite an important one, isn't it? So we've kept quite an eye on that during the pandemic as a whole, and we recognise that maybe we'd heard in other areas where things like domestic abuse, maybe there's a greater risk, greater likelihood. So we did actually keep our safeguarding team running during the pandemic, and increased numbers of people that were also responsive to safeguarding concerns. We didn't actually see any significant number increasing, so but we did keep an eye on that, and we will take something to the Quality and Safety Committee this month just to confirm that position. The other part there was I've also asked that we look through IMT and review the incident and how we've managed that, so that we don't lose that richness. I'm sure, you know, nationally this will all be looked at as well, but I think it's important that we don't lose some of the, you know, the quality of that information now. But if you remember, when we did go into lockdown, there were some very clear instructions, so we followed the national policy, and if you do recall, we were expecting quite a significant peak at the end of March, which is why we responded really quickly. So I know I'm just probably going to remind you all that we actually did retrain and redeploy. So we retrained over 300 people and redeployed over 200. And going back to David's report earlier, we had a peak sickness of 8.4%, which is now averaging around 5.5%. So we did find that some teams, to be fair, did feel that they got an oversupply of staff. I don't really make much of an apology to that, to be honest, because we were concerned that maybe if lots of staff did go off, that would have been really, really tricky. And again, we can look at that in the fullness of time, you know, in terms of learning. But to be honest with you, the fact that we didn't get into any tricky positions, I think is also a good thing. So I understand, and I think Jo's reflection is extremely good, and I've read it and gone through it, and I think that personal account, I think when you look at other staff members that have also been redeployed, I think it's a fair reflection of probably what others think, and as Jackie might point out at some point, we have seen variable levels of anxiety from those that cope well to those that have struggled perhaps even more. So I think it's a fair reflection, but I just wanted to pick up on the point about our decision making as well, just to, I guess, remind ourselves about what we did do at the end of March.
Thanks for that, Steve. Hamish, I can see you're indicating, but Steve, can I just come back to you quickly to, if you could just outline, I know we were following national guidelines in terms of redeployment of staff. On the face of it, in terms of what we've heard, some vulnerable clients were left without support, and I wonder what process was undergone in order to make that decision that we would leave that client group and redeploy to support others.
Yeah, sure, and maybe Joe can add to this a little bit in terms of what was the contact point for those they did need to get in touch with the service as a whole, or indeed, as Joe pointed out, social work support during that period of time. We would, I believe, have then responded, because the service that Joe is part of in terms of the Family Nurse Partnership, and Joe will know much better than me in terms of the nuances of this, but it's actually a prescribed and very prescriptive model, isn't it, Joe? Which we have to maintain fidelity to. So there is...
yeah. It's a licensed programme, yeah.
Yeah, so there are some important things there. But Joe, do you want to just add a little bit to the point that Nuala's made about for those young parents, the contact point that they would have been advised to make?
Yes, yeah, I mean, in regards to the safeguarding, I think, as you know, Steve, a lot of it goes unreported. So a lot of incidents when we came back, we found out had occurred that hadn't been reported, because the nature of some of these girls is that it doesn't always go to the police, it doesn't always get to social work, and we find out several weeks or months on. I think in terms of the support, I actually found that our direct managers really did listen, because when one of our colleagues was left, her husband was shielding, so she couldn't be redeployed. So she stayed and was basically a telephone contact for the clients, for all of our clients. That was, 97 of them, which she found almost impossible to manage. And we actually did go to our manager, and she did take that on board. And we actually had one of our staff come back from the adult district nursing team after 3 weeks, because it was impossible for my colleague to manage it on her own. And then there was a slow, steady return back. One of us went on maternity leave, and then another girl from the CCN team came back 2 weeks after that. So there was a steady return back, because they recognised for our service we did need to return fairly soon. So we were listened to. I don't feel there was a point when we weren't.
So I think, Nuala, that probably just...
That's really helpful.
Yeah, okay.
No, that was really helpful, Joe. Thank you for that. Hamish, I know you were indicating to ask a question.
I was, Chair, I think, but you picked it up in your question in terms which was around the services that were neglected. I'm happy with the response we've had from Steve. Thank you.
Think you. And David?
Hi, thanks, Nuala, and thanks, Joe. I'm the Chief Executive of the Trust. I don't think we've met even virtually. So thank you for giving your account, because I know it's slightly intimidating to do these sorts of things, and I think you've been very honest, and that's incredibly helpful. So for the board to kind of get a real flavour for all the challenges we've faced as an organisation, as you as an example of our members of staff having to face dilemmas yourself professionally about how we manage this. So I was just going to sort of reiterate Steve's point that we had a structured process for doing this, and yes, we did do it really fast. And as Steve said, I think everyone understands the context for making really fast decisions in those early days there was a very, very significant anxiety about the potential for the NHS to be overwhelmed with COVID-related demand, and fortunately, the peak was nowhere near as high as we feared in those early days, but it could have been. And we as an organisation and we as an NHS nationally were making judgment calls really in terms of relative harm. So of course there is of course, there are consequences of stepping services down or making them kind of skeleton versions of their normal service levels. And obviously that applies from everything from sort of service Joe works in through to elective care and beyond. So there's absolutely no doubt there has been consequences of the way we as the NHS have managed this crisis. I think, and it's all been a balance of risks, really, hasn't it? So we've had to make really fine judgments. I think what Joe's also described very helpfully for me is that flexible response. As we've started to see the demands weren't quite as high as we feared, we've been able to release staff back into their core roles on an incremental basis. And now in our restore and recovery planning, we've started to bring whole services back. So Joe again is in a service we've now brought back to be, I think, fully operational.
Yes, it is.
So it's been a really difficult balancing act of risk management, I think, and that's Joe's brought that to life really in terms of a real life example of how we've had to deal with that both as an organisation and as individual members of staff working within services. So yeah, really to end where I started. Thanks very much, Joe, for your accounts. Really, really helpful.
Thank you for listening. Thank you.
Thank you for that, David. And Joe, from all of us, thank you so much. It's very valuable to us to hear this, and we love to hear where things have gone brilliantly, but it's very important that we hear where we perhaps could have done better. I am assured to hear that we were responsive to the concerns raised by you and your colleagues, and that we were able to adjust accordingly. I'm sure lessons will be learned. I'm also well aware, Joe, that as you go back to your day job, as it were, your normal job, you'll be dealing with some of the consequences of what's happened over these past few weeks. And all I can do is, wish you well with that, and thank you for all you've done, for all the service that you've given. It's so much appreciated and so valuable.
Thank you very much. Thank you all.
Thank you.
Bye-bye.
Thank you.
Thank you, Joe.
Bye-bye. Bye-bye. Right. That was really good, Steve, and I think there's more discussion we'll have on that. Nobody ever thought it was going to be perfect and seamless, and I think that just demonstrates, what it's like when you're managing in an emergency situation, and I do feel that appropriate action was taken and reaction when it was needed. Sorry, you wanted to come back.
Only just that I think what Joe did go was a very balanced view, actually, from what worked well and what didn't, from her perspective, work so well. But actually, I'd describe it as it was a real life account of how it was for Joe, and that comes across in her article, which I will share later.
No, that'd be great. What also came across, and I should have said this to Joe, but I'll put it on record now, was her commitment to her client group. I mean, that's why she felt so conflicted. It wasn't that she wanted in any sense to be non-compliant, but she was just so committed to the clients that she knew, and she recognised how difficult it was going to be for them to be without support. So, that's the kind of dedication that that shines out from all our staff, and
absolutely, Nuala. I think
really appreciated.
And I think Ros would endorse, they're an incredibly passionate and committed team, aren't they?
Yes, they are. And I wasn't surprised at all by that. It's just really good to get that perspective today.
Yeah. No, that was really good, really helpful. Thank you. So we'll move on then to the next item on the agenda, if I've got this right. It's the Quality, Safety and Productivity section. 9.1 report from Peter as chair of Q&S. Over to you.
So this report gives a summary of the matters that we discussed at our last committee meeting, which was a full and robust meeting, I must say. It's pleasing that we now have a framework upon which we can report to the board our consideration of assurance. So you'll see that we discussed 10 reports at the last meeting, and overall we could provide the board with assurance, 7 of which were substantial, 2 moderate and 1 limited. And for the reports that were moderate assurance or limited assurance, they remain on our action plan to receive further information on the way back. The other thing I'd like to mention or highlight within the report, and that is the Executive Director of Nursing Awards, where Steve has kindly mentioned or awarded to 6 individuals in a team for their hard work, which we thoroughly endorse. I suppose just one thing to mention there with this report, and that is, as far as the safeguarding element is concerned, we did receive a report from the safeguarding lead from the Trust, as this is a very important aspect of our work, and we were at the time with this report being able to provide you with substantial assurance. That doesn't say we rest on our laurels as such, and certainly welcome the comments that were made today by Joe and the further comment from Steve for following up any considerations in that regard. So open up to any questions.
Thank you for that, Peter. I agree with you. It was a good meeting and lots of robust discussion for those of us who were there. Are there any questions for Peter on that? Steve?
It's just worth the one that's got limited assurance around physiotherapy and speech and language therapy, wait times in particular. The reason it got limited assurance is the recovery plan was not on track. So we'd asked for that to go back to the committee, and the only way that we could then receive assurance is if the numbers of people then waiting were reducing in line with the revised recovery plan. So that is coming back to the Quality and Safety Committee this time, and we've been keeping at least a weekly, from my perspective, eye on things. And I can confirm that when that does come to the committee this month, that will show a significantly improved position, and that the trajectory now is on track as well. So probably just that update for the board, if that's okay.
Yep, thank you for that, Steve. Tina, I think you were next.
Chair. I don't know whether I'm jumping the gun, perhaps we'll put this up later on, but just new birth visits. I don't think we had a discussion at Q&S particularly about it this time, but we have picked it up before. But just thinking about the safeguarding theme, there's still a few people who, for probably legitimate reasons, aren't having the new birth visits, and in the report it says unavailability of parent or patient choice. And I suppose it's just going back to that safeguarding theme again. Are we assured that we're not missing any safeguarding issues by those parents making that choice or not being available? I don't know whether you've got the answer.
Well, that might be one for Steve to answer.
Yeah, if we could bring that into the committee, I think it would be a helpful discussion, because obviously over the last couple of months, obviously we've had to adapt how we do that, and people not being available is not being the same, as you can probably imagine, with the guidance. So, but people have risk assessed in terms of the type of contact that would then be deployed. So there has been telephone contact with people, which is obviously different to how the guidance has been enacted prior to that, because, as you know, it had to be face to face. So if we could pick it up in more detail at Q&S, but it has been quite a different picture, I would say, over the last couple of months.
That would be really helpful, Steve. Thanks.
Thank you. Ros was next, and then Peter, I'll come back to you.
Thank you, Nuala. I just wanted to add to the point that Steve had raised around the access times for our services. I know you were probably jumping around in terms of the appendices, etc., because I'm jumping over the Learning from Death report, but the quality report does make reference to broader aspects of our access times deteriorating across our services. I'm going to pick that point up later with regard to our overall dashboard and the development of indicators that help us look at how we recover and restore services. So I think there's just a broader point. So I just wanted to sort of highlight that now. There is more detail in the quality report appendix, but I do want to pick that up later when we talk about the developing dashboards in terms of restore.
Thank you. I see you, Peter Phillips, and
Oh,
but
good.
Peter Featherstone. I'll come to you in a moment. Peter Featherstone, you were next. So.
Yes, it's just to follow up on Steve's point with new birth visits, because this is something that I've always, or rather regularly raised as a matter where we do need further assurance. I do recall at previous meetings we did say that we was awaiting for further guidance, national guidance with regard to new birth visits, because I think we'd set our target at a certain level that we decided ourselves, and that we needed review. So I'd certainly welcome further attention by the committee in regard to how we're going to deploy guidance and how we provide further assurance to the committee, Steve.
Thank you for that, Peter. And Peter Phillips?
Yeah, I'm just picking up on what Ros said then about recovery, and what caught my eye in the report was 2.2, recovery plan for children's physiotherapy, etc. Had limited assurance overall. And is there further reports coming back to QNS on that? Does it sound, it sounds a bit serious, but it may just be inevitable that some services are dropping away a bit in the current circumstances.
I think that was the point, Nuala, that I made. That was the specific point, Peter, about the recovery plan. And it was me that was saying that we could do better. And
apologies.
It's okay, but Peter Featherstone, I think we've talked about that, haven't we? And like I say, at this month's QNS, you will see an improved position.
Thank you for that. If there's no more questions on that part of the report, I can move us on to the appendices. The Learning from Deaths report we did discuss fairly substantially at the committee, but we need to bring it here for full approval. Jane, if I can call on you just to, as it were, present it.
Yes, so what you've got is the appendix, rather than being the report that was actually taken to Quality and Safety, is a report that describes the outcomes or summarises the content of that report, but also includes the outcomes of the discussion at Quality and Safety Committee and the assurance that was agreed. So as usual, this report delivers the statutory reporting requirements of deaths between February and the end of April. It also demonstrates assurance of compliance against the national framework. And we particularly had a discussion around COVID deaths, of which we had 5 COVID related deaths by the end of April. It was decided that we should be reporting COVID relating deaths more frequently than required by the national framework. So we're in addition going to be reporting COVID relating deaths monthly to Quality and Safety Committee. The Quality and Safety Committee heard how we'd adapted our learning from death process due to COVID in line with the reducing the burden document. But we are now resuming the processes in full, and we've taken the opportunity of involving our internal auditors, BDO, in preparing the board report, the Quality and Safety report, attending the Quality and Safety Committee and preparing this report. So it also includes some feedback from them on how we might be able to strengthen our processes and thereby the assurance to the board. So I won't specify anything more, but very happy to answer any questions.
Thank you for that, Jane. Are there any questions for Jane?
Yes, can I just come in then, Jane?
Yes, Harmesh.
Learning from deaths in terms of how do we actually get families and carers involved in these case reviews, and what's the process of looking at case reviews? How do we sort of, look to, how do we select the cases to be reviewed?
So we review every patient that dies in one of our community hospitals. We're required to investigate unexpected deaths, but we haven't reported any unexpected deaths over, I think it's probably 18 months now. So there is, with unexpected deaths, there is a formal process which absolutely involves family and carers. However, we look into every death that's occurred within our community hospitals. We, at ward level, are reports compiled immediately, and you'll remember we're doing an audit of the quality of those reports at the moment. They're collated by the locality managers on a monthly basis so that we can identify themes either within hospitals or across our trust. And those are developed into the action plan, which you have a summary of, where we can demonstrate based on themes that we're addressing anything that we can improve on, and beginning to demonstrate the impact of that, which is where I think our reporting hasn't been as strong previously. So we would involve, I mean, because the information is collected at ward level, it does include information from family and carers. And clearly, if we had any concerns or complaints in addition to our normal reviews, we would also involve the carers and family. Does that answer your question, Hamish?
It does. Thank that was helpful, Jed. Can I just follow up on that? When you're reviewing the cases, what kind of training do we provide to those who are sat on those panels reviewing these particular cases? What level of training do they have? Is it clinical training? Is it sort of training in investigations? What's the level of training involved?
I think the clinical aspect is important, that the reviews are done with clinicians, and both clinicians that have been involved with the case, but also others, and clinicians of different levels of seniority. And our Learning from Death group, which reviews these, consists of a number of senior clinicians, including our community hospital doctors. But the training is something that hasn't been formalised previously, but is in our plan. I think you'll remember that there's a series of levels of training that Jackie's been organising, partly around generic report writing. So Jackie might be able to update more on this, but generic report writing across the trust, but to include something more specifically about report writing from Learning from Death. It also links with the work we're doing around the learning cycles and how we both do learning cycles and do the report writing, not just for Learning from Death, but complaints, concerns, PALS, other opportunities we have to learn. And so that's something that we're aware of and building on.
Sure. And finally, Jane, I mean, any death is a tragedy, but 22 deaths, in the child category, it's a lot. I mean, what is that telling us in terms of the deaths that are taking place with regards to infants and children?
So the infants and I haven't got the report up in front of me now, but the child deaths isn't that's a regional figure, so that's not relating to Shropcom. Right. So clearly the CDOP process is in addition to everything that we do, and that's reported at, well, it's regionally, but actually the regions now includes Herefordshire. They've just grouped the regions, so that's not relating to our trust. Well, it includes our trust, but it's much broader.
On the report, it would say Telford and Wrekin in Shropshire.
I'm going to have.
Does that include Hereford now?
I'm sorry, I'm going to look at
2.3 paragraph.
Is there any way, Claire, can you get that up? I don't, rather I disappear into my...
Page 43 of the pack.
Yeah, I can see it as 2.3. The number of Shropshire and Telford and Wrekin child death notifications for 2019-20 is...
Oh, 22. I see, sorry. Yes, that's the... For the year, I understand. Yes, and I think very much the majority of these are infant deaths, and so I mean I can't really comment on the fact. Clearly, as you say, any death is a tragedy, but this, I mean, we can get more data for you, but this wouldn't be an unusual number across a period of a year.
Okay, thank you, Jane.
Thank you, Harmesh. I think, Kathy, I think you were next indicating.
Thank you, Chair. Jane, the question I have relates to the patients being able to be discharged home for end-of-life care due to delay in continuing healthcare processes. And I was wondering where we were around that, because it's so important for the patient and the family. They have a choice at this very difficult time for them, and what we could do to help around this, if that's what's required.
So so that's been a piece of work that we have been, we've been working on that for some time. However, one of the things that's happened due to COVID, which is actually an improvement, is we now have a system-wide discharge to assess process that was implemented at the beginning of it would have been the end of March, with immediately the risk of a COVID surge was with us. It builds on the discussion we had earlier about how quickly things needed to change, and through that the discharge is no longer delayed by continuing healthcare. As soon as a patient is medically ready to discharge, that is arranged, and the funding and care is wrapped around the patient with their discharge. So it is something that actually in the system has improved over the last few weeks, and our the next step is how we maintain that. But continuing healthcare is still functioning, but it's not delaying patients from discharge.
Thank you. That's really good to hear. Thank you, Chair.
Thank you, Kathy. David?
Thanks, Nuala. I mean, on that last point, I guess the issue is what the rules will be as we return to normal, and whether continuing healthcare processes are reinstituted or not. But I completely agree with Jane. It's been one of the kind of positive consequences of how we've operated differently, and it'd be great if we could maintain it. I was just going to reiterate, I think the importance of these death reviews, particularly in this COVID period, because as you all know, nationally there's excess mortality, quite significant scale as a result of COVID, and the move to both strengthen our generic approach to this process and to focus on a more rapid review of deaths in this period, I think is completely right. So I just want to kind of highlight the importance of that. And Jane, we've been talking about the potential to widen the scope of the death reviews, because we do only focus on community hospitals at the moment, and obviously there are our patients in the community will, by nature, some of them will pass away, but we don't currently review those in the same way. And we know one or two other community trusts have got interesting ways of addressing that. And so I know, Jane, you're planning to follow up on that. So I don't want to commit to any particular timescale on that, but I am quite keen we look at the learning from elsewhere.
I mean, so the requirement is for us to review the deaths of patients that are in the community hospitals, and also anyone within our prison services, and all children and all people with learning disabilities. However, our ambition is that we will be formally reviewing all deaths of patients that are in the community but that have been under our care. Now, the patients in the community under our care are the responsibility of the GP practices. So this is something we need to do collaboratively, and it's something that we had already started exploring, in that we want to start getting our teams to just ask a few simple questions so that we begin to get some information around patients that we have that have passed away under our care. But we've also got, you might remember, we've got Niche, well, they were about to start a system-wide learning from death review, and that will very much enable us to work across the system, which is what's going to be needed, because many of the patients in their own homes have got the GPs and probably the acute hospitals taking part in their care. So we need to do this as a system. So we are inching towards it, but we are also have that ambition for system work, and that review will be, hopefully we'll pick that up as soon as possible. I'm liaising with Niche next week, and as David says, I'm also liaising with some other community trust medical directors, including one in Leeds, who I'm talking to next week, where they do this to some extent. So something that I'm hoping we can pick up as soon as possible. It doesn't need to be delayed because of COVID any longer.
Thank you, Jane, and thank you for raising it, because I wanted to ask that question. Right, I see Peter Featherstone is indicating, and Kathy, you've got your hand up. Have you left it up, or did you want to come back?
Thank you, Chair. Just to provide additional assurance, so I have the genuine pleasure of being on the Learning and Deaths Committee as the NED representative. And just to provide the assurance that certainly Jane and I have spoken about learning from deaths from the community, and that is a topic that we do wish to explore, and I look forward to having further conversations with Jane in that regard. And just to reflect back upon the comment that Harmesh made earlier that Jane responded to with regard to the child death notifications, each one of which is an absolute tragedy. From my attendance at the meeting there, I did hear that almost all of these were due to unsafe sleeping practices. And the challenge which I did note then and raised at the committee was how the system as a whole, not just ShropCom, but partners, how we can actually communicate the message of safe sleeping to families. But that was on the agenda and remains an ongoing live point of concern.
And clearly that relates to the conversation we had earlier about newborn baby checks as well, and any opportunity that we have to pass that message on. So we've had some in-depth discussions about that at Quality and Safety and in the Learning from Deaths meeting. Clearly this is being reviewed at a regional, and national level as well. But B has been trying to use any opportunity she can to get communications out via the teams, and this is frustrating because it remains an issue. But Steve, you may want to add that I know that our teams are doing everything they can to share the message, but it is still a regular tragedy.
Yeah, and if you remember, B did actually come to the board where I think David, you came to Shadow just before you started as the chief exec and made that very point, and back to Peter's point, it's the public health issue as well. Just to be clear, there was a query which we're going to take back to the Q&S committee about the data about the child deaths, about where that data was extracted from.
So one of the charts was inaccurate. It's not actually one that's in the report that you've got today, and that was corrected. So, but it doesn't impact. It wasn't actually the data that was wrong; it was the labelling. So that's been amended in the Quality and Safety report.
Okay, thank you, Jane, and that's been a good discussion, and this was discussed thoroughly as well at Q&S. This report is there for approval, so can I ask that you all approve the report?
Yep.
Formally.
It would be helpful, Nuala, just to, if anyone's got any comments on whether this is the quality of the report is improving and whether we're on track with demonstrating greater assurance than we have been, because that has been raised previously. I mean, we were pleased that we were able to demonstrate substantial assurance, but it would be helpful to just hear from the board what they think and any other suggestions.
Thank you. I think that's going to be an ongoing conversation, but point taken. I will say I think this was a very good comprehensive report, and the discussion I think has reflected that. So thanks very much, Jane.
Thanks.
Okay, the quality report. Roz, are you presenting that one?
It might be me,
9.3.
Yeah, no, sorry, Nuala, it's not in. I'll say not in my section. I'm quite happy to chip in and contribute.
Right, it's just that Alison is down as reporting it. That's why I thought it may have been Roz. So
unless there's been a management change and somebody's moved Alison to Roz, apologies, Nuala, it's me, Steve.
It is you.
It is indeed. So again, it's there. People will have read it. It's gone to the committee. I'd be happy to take questions. There's one thing that isn't in there though, which I made reference to at the committee, and I'll make reference to today at the board, is we were provided nationally with what was called an Infection Prevention and Control Board Assurance Framework document. It's a set of 10 questions that are taken from the IPC Code of Practice. It was intended for directors of nursing in particular, or DIPSIs, to use that to test out their organisation's position in relation to IPC during the pandemic. But it also says that it's useful and good practice to then share that with the board once it's completed. So I can tell you today that we did do a first draft, which we shared with execs. We're testing it out with all the community hospitals, and that will be completed by Monday. So that's the 8th of June, I think, if I'm correct on my dates, might be wrong. And then it's on the agenda for quality and safety in June. And then I was going to bring that to the next board meeting in July, if that's okay, Nuala. But what I can say so far, from my perspective, having gone through that, and exec colleagues have seen it, there is nothing that's standing out in terms of anything significant in terms of assurance. My probably plea would be, and it's something that we just have to keep repeating, it doesn't matter about the pandemic, is never be complacent in terms of basic things like hand washing. And that's one of the things that I think strikes me, not that we've got a systemic problem, but it just, I think it's just worthy of reminding ourselves consistently and all the time that those basic things are required. And I think when we get into restoration and recovery, and perhaps more people are coming into some type of contact with others, that'll become increasingly important, I think, to just keep an eye on.
Thank you, Steve. Thanks for that. Tina, you have your hand up.
Thanks, Chair. Steve, it might be a discussion for the next Q&S, but just on pressure ulcers, I think from the data that's presented, it's really hard to know the level of improvement we're getting, because from the data that is on the graphs, the numbers of patients that have acquired pressure ulcers in our care has gone up, but so has the number of patients in our care gone up. So it's hard to know, are we seeing a percentage improvement or not? And I just wonder whether we can think about how the data's presented, because I'm not sure we're getting a real reflection of how we're improving or not, as the case may be.
Of course, yeah, we can certainly consider that. I think it's probably just worth noting for today, though, that if you look back over 3 or 4 years, then definitely there is an improvement to be noted.
Yeah.
But the guidance in terms of reporting pressure ulcers changed also about 12 months ago. So it's quite difficult to kind of go back and say, compare A with B and then correlate that. But you can see in the data that those with the grade 4 pressure ulcer have halved, haven't they, from 4 to 2.
Yeah.
The others, it's less discernible to note with the data. So definitely, Tina, we can bring that back.
Yeah, that doesn't take away all the good work that's going on. And I know there's some excellent improvement work that's being recognised.
Yeah, and it probably is just worth noting those that are directly attributable to, say, a care failing, and those that we're reporting that we're seeing within somebody's own home or a nursing or residential home. So again, if we split that data out in that way, I think that's also
perhaps a fuller discussion for Q&S. But yeah, thanks.
Thank you. Thanks for that, Steve. If there's no more questions on that, on the quality report, Steve, can you, assuming it's you, on the well-led assessment?
Yeah, so what we specifically did here was to think about how we'd responded to COVID and the pandemic, and then apply the well-led standards. And we didn't do that just because Becky was joining us today, because we didn't know at the point that we did this review.
Although it's quite helpful that Becky is there.
Indeed. So yeah, so basically we did that, and it's gone through Q&S. And again, happy to take questions, but we thought it's applied a really good structure to make sure, again, that we're not losing things that we've done so far. So when it comes to a fuller review about how we've responded to the pandemic, this will be one of the documents also that we'll use to evaluate our response so far. So I hope that you think it's A, it's useful, B, it's clear, and C, I think the structure of it seems to work well. But maybe back to Jane's question earlier, does that work for the board?
I thought it was a really good report. It's the first time I'd seen it here, and I thought it was excellent. Over to you, colleagues, then. Tina?
Thanks, Chair. I think it's an excellent report, and it's really, really helpful to see where we are, Steve. Just one question I got. It's on page 79 under culture. In terms of COVID, and we're saying we haven't systematically tested how staff feel. And I just wonder, and it might be something Jackie wants to comment on, given the staff story we've just heard as well, is there something we need to be doing slightly more systematically across services to see how staff feel? And we talk about this anecdotal evidence.
Yeah, I think probably Jackie will jump in a second, but the reason we put that is we obviously haven't done that in a systematic way, but what we have picked up, because maybe Harmish's points earlier, we have kept in contact with teams and people, and also looking at that through redeployment and restoration. So we've kept a really close contact with people. So we've got I believe we've got a good appreciation of how people are feeling at one level, but it's at one level. So should I just give way to Jackie to contribute?
Thank you, Steve. Yeah, I mean, I do think it's been absolutely central to the way that the IMT has operated, led by Steve, and so whatever change process that has been adopted, the management team and the HR teams have been working together to make sure that the staff are supported, which is very much in line with our core values. We've had, at the same time, we've done lots of communications around what we have available for people, and in actual fact we haven't had the pull on our psychological services that we originally thought that we might have. So it's been more around supporting teams. And then the other thing that we've been doing is making sure that, whilst we've been supporting people locally, I have to say that the national offer around health and wellbeing has been ramped up, and we've been communicating the things that are available. We've done, we've got a stock take regionally on good practice. We're just looking at that at the moment. And we've also got an exercise where we're going out to every member of staff, which we did at the beginning, to see how they were working, what support they needed. And we're about to go back again with the theme of how we're moving to the next stage. So I think we could be confident that we are reaching out to people. We've set communications out directly with line managers around how we are expecting to meet whilst we're working and support people whilst they're working in very different ways. We have got a couple of things I think we need to do specifically around supporting teams to work together. We know that's where resilience lies. So I think it's not necessarily individual issues, it's teams, and we have got more work to do on that.
And particularly, I suppose, sorry, can I just come back? Particularly as, no, it's all right, as services start to get re-established. Again, the staff story we heard this morning emphasised that point, I think, about the importance of when teams start to get re-established.
Yeah, absolutely. So we've got a process being designed at the moment that where we will talk to everyone through line management and provide and capture kind of, actually people will feel quite anxious, and people feel very anxious about as things change again. So yeah, we are planning for that.
Thanks, Jackie. There's a few questions now piling up. I think Peter Featherstone, you were next.
Thank you, Chair. Yes, certainly. I certainly welcome this report at the Quality and Safety Committee, and certainly I feel confident with substantial assurance there. But personal reflection, this is our self-reflection, as it were, at the peak of our activities. I'm sure that we collectively are keeping all these domains under ongoing review. And personally, I'd reflect a refresh of this report as and when we get to the end, if I can call it as such, of the COVID-19, whenever that may be. At that time, when we actually look back at what we achieved, lessons learned, what went well, etc. So possibly if we can put this on the forward plan for, I don't know, 3, 6, 9, 12 months hence, that we actually have a refresh.
Thank you for that, Peter. That's noted. Jane, you were next.
Just wanted to add a couple of examples around how, because of remote working, we've perhaps been able to spread our, enable leadership at all levels across the organisation more. So one of them would be around our connecting the community hospital medical advisors, which we're now doing on a weekly basis. And when you think it's been difficult to be able to get all of them together in one meeting ever, we tend to not be able to do that. We're now being able to do that on a very regular basis. So from a sort of clinical leadership point of view, that's really productive, and it works. And then the other thing is just connecting people on a very regular basis. So we have a weekly check-in with the medical dental leaders regularly. But yesterday we just opened up a virtual forum. You'll be aware we've started up a medical dental forum that meets sort of every few months, and we thought, well, let's put one in to see whether that's effective. And actually it was incredibly productive, and it was partly around checking in, but partly around making stuff happen. So I think now we've got this, well, I know we're going to be coming back to it in later papers as well, but having this virtual technology is actually really key to leadership with such a dispersed organisation.
Thanks, Jane. I have to agree with you. I think we've learned a lot these past few weeks on, how we can stay connected. And, I do hope that we will capture this and continue some of this in the future. So, Kathy, you were next.
Thanks, Chair. I was wondering, particularly Jackie, that we haven't made more of the work we've tried to do with our BAME staff, who have really had difficulties during COVID across England, Wales and Scotland. And I wonder whether we're missing some pieces of action in that report that I think should be highlighted around the work we've done, or whether that will be picked up at a later stage.
Jackie, do you want to come back on that?
Yeah, I'm happy to talk about this. I mean, there are a whole range of things that clearly that we, from a workforce perspective, that we are supporting in connection with this. We've seen directly the agreement to some extraordinary terms and conditions that we've put in place. We've got a risk assessment process for all staff, but in particular for vulnerable staff, which is in motion at the moment, and that is a really significant, important piece of work to make sure we've got it right for staff. One of those categories is our BAME staff, and we've had a report only this week from Public Health England on the disparity of health outcomes, not just for BAME staff, but for all. And that report tells us that pretty much what happens in terms of social deprivation is mirrored in COVID. So for our BAME staff and other vulnerable groups, because if you've read the report, what it shows you is perhaps one of the highest risk group is men of working age, the death rate there. So we need to make sure we look at all of those areas. We've produced guidance. The risk assessments need more work on them, I think, just in terms of making them effective, that managers can use those appropriately. For our BAME staff, we did a piece of work that we coordinated centrally within the STP, and I led on that, and we did We looked at best practice. We're linked into regional meetings. We've got a meeting tomorrow around this, and making sure that our practices are picking up any emergent, because a lot of information is emergent. So and I think just rather than going through the whole programme, to say that we're in the process this week. We've got a deadline this Friday of doing our BAME risk assessments and vulnerable staff, and then aligning any particular actions and support to staff accordingly.
Thank you.
Yeah.
No, thank you. Thanks, Jackie. That's really helpful. David.
Yeah, just on that last point, Kathy, I think the report for next month's Policy and Safety Committee I would expect to include all the actions that Jackie's just talked through, because a lot of those are still in process at the moment.
Okay.
So like, right, I would. It clearly is an issue which we should be and are focusing on. So it's important that we make sure that's reflected in our reporting. I was just going to come back to Tina's question about a kind of structured process for getting feedback from staff. So everything we've described so far is really incredibly valuable, and probably more valuable than what I'm about to describe, in that it's about getting direct conversations with our individual staff, making sure we're supporting them appropriately, etc. You'll probably know the National Staff Survey has been suspended, so that isn't running this year. But within the system, there is a proposition, I must admit I've slightly lost track of where we got to on it, that we do some local version, a simplified version of a survey of all staff. So we do get some kind of quantitative data, as well as the qualitative approach that we've been describing. So Jackie, you may be slightly more up to date than I am on that, but that is the intent. In part of our learning from COVID is to have something along those lines, in terms of not the equivalent of a staff survey, but something that's stepping into that void, if you like. So Jackie, are you wanting to come back on that?
Yeah. So I think so. What there will be nationally is that they're describing it as a pulse check, and what we don't know yet what that looks like. But I think, as David's saying, really, I think that will be aligned to the particular situation in which we find ourselves, bearing in mind that the staff survey is there to measure a whole range of things that probably aren't wholly relevant during this period. So that will be, we're expecting, we were told that will be available this month, but it's certainly imminent. We wanted to get in the STP ahead of that and say, well, actually, we do need something in our STP in any case, and actually the staff survey, as we all know, is a once a year approach. So we want to do something that is more dynamic, that goes through the year in any case, to pick up, and we'll adapt it initially for this situation in which we find ourselves. So as part of the national approach, I think we would be expected to do this locally as well.
Jackie, thanks for that, and thanks everybody for the report. That's been a good discussion. Are you all happy that we accept the report? That is there for assurance. So thank you. I think we can accept the assurance given in the report.
Yep, excellent.
Yeah.
Okay, and then briefly to you, Jane, for the Guardian of Safe Working report. And I note that we need to approve this. It is a regular quarterly report, is that right?
That's right, it's a quarterly report, and I do need to ask the board to approve this. Essentially, we had 2 junior doctors working with us at the point that that COVID arrived with us. So they were both redeployed fairly swiftly into the acute trust, in line with national guidance. And they're coming back to us on the 22nd of June, which is very nice. And I think they're looking forward to that. But there haven't been any reports of concerns during this 3-month reporting period. So.
Thank you. So we need to approve that report, colleagues, if that's all happy to approve it.
Yes. Yeah.
Yep.
Fine.
Yep. Thank you very much for that. Thank you. And I think bang on time, or almost. It's coffee time. So thank you all for this first part of the meeting. Time for a quick break, and see you all back here at 11:45.
Can I, just for Louise's sake, suggest we pause the recording so we don't have a long gap for for when we
I'm not
post it
sure
online?
we can do that. We had that problem last time, didn't we?
We've just stopped. You can't pause it, but what we'll do is we will list it in 2 sections, so before and after coffee break. But yes, if we stop recording, and we'll do a second recording after the coffee break.
Yeah. Okay. Thanks.
Okay. See you in 10.